Welcome to our sixth episode of Antibiotic Answers, where we take your antibiotic questions and give short, guideline-based answers while focusing on using antibiotics appropriately and preventing resistance. This episode is about antimicrobial stewardship in the emergency department. Our first question is, why is it important to prioritize the development of antimicrobial stewardship programs in the ED? The ED has been considered the heart of the U.S. healthcare system, with roughly half of all medical care occurring in the ED, and this is continuing to grow each year. Antibiotics are one of the most commonly prescribed drug classes in the ED, and they are often inappropriately prescribed for all infection types. The CDC reports that at least 28% of antibiotics are inappropriate in the U.S. Additionally, antibiotics are the second most common cause of adverse effect-related ED visits, and about 1 in every 1,000 prescriptions leads to an ED visit. Despite these facts, the ED has been underrepresented in stewardship efforts as most focus is aimed toward inpatient management. For our next question, what are stewardship considerations for emergency departments? There are 5 Ds recognized for antimicrobial stewardship: dosage, drug, de-escalation, duration, and arguably the most crucial in the ED, diagnosis. It's important that EDs are utilizing imaging, biomarkers, and rapid diagnostic testing to achieve accurate diagnoses. This allows us to assess whether we can delay starting therapy or determine if we even need antimicrobials at all. For example, rapid diagnostic tests like PCR have quick turnaround times, which are essential in the fast-paced environment of the ED. Also, biomarkers such as procalcitonin, as well as these rapid diagnostic tests, help distinguish between bacterial and viral infections, thereby preventing inappropriate antibiotic prescribing. In a 2019 randomized clinical trial, rapid respiratory pathogen testing led to 12% less antibiotic prescriptions in patients with upper respiratory infections, demonstrating the impact of rapid diagnostic tests. On a similar note, because things are moving so fast in the ED, sometimes cultures are forgotten. It's crucial that ED staff are appropriately collecting cultures before starting antibiotic therapy, since they allow us to identify pathogens and their sensitivity, which then supports de-escalation of therapy. Inappropriate empiric therapy regimens can significantly impact antibiotic use. Because decision-making in the ED is rapid, it's easy for providers to choose a broad-spectrum antibiotic as a quick win. In addition, empiric therapy is often continued by other healthcare professionals during the initial days of treatment. Accordingly, ED should consider a watchful waiting approach, in which patients are monitored for worsening symptoms while awaiting cultured results. This can include a follow-up phone call, in-person visit, or providing patients with symptom self-monitoring instructions and when to seek further medical attention. Another thing EDs can do is limit the use of certain broad-spectrum antibiotics by implementing a defined formulary or establishing criteria that require the prescriber to give justification for choosing certain antibiotics. Our last question is, what are examples of stewardship interventions for EDs? Guidelines recommend that EDs implement ED culture follow-up. This is typically done by reviewing cultures, and if a patient is receiving inappropriate therapy, the regimen is adjusted. Then the patient is contacted about the culture results and a new prescription is sent to the patient's pharmacy. The follow-up should also address the patient's symptom improvement and any questions they have. Studies have found that ED pharmacists can have a positive impact on antimicrobial stewardship, including lower readmission rates, less time to culture review, as well as improved therapy management, including antimicrobial selection, duration, and dose adjustments for hepatic and renal impairment. Developing ED-specific antibiograms annually can aid in antimicrobial selection and monitoring resistance over time. Smaller facilities can do biannual antibiograms or combine data with other local EDs. Studies have shown that traditional educational approaches are not as effective and that implementing behavioral interventions like audit and feedback, one-on-one education, and peer comparisons may be more impactful in improving prescriber outcomes. Finally, utilizing public commitments, such as displaying posters in exam rooms that highlight the facility's commitment to avoiding harmful antibiotic use, can encourage providers to be more cautious when choosing antibiotics, knowing that they have committed publicly to patient safety. Posters like these can be found on the CDC website. As an example, a 2014 study implemented an electronic order set along with a 2-month period of audit and feedback in ED patients with urinary tract infections. They found an increase in guideline adherence from 44 to 82%, a decrease in fluoroquinolone use from 44 to 13%, and a decrease in unnecessary antibiotic days from 250 days to 52 days, demonstrating the positive impact of making antimicrobial stewardship interventions in the ED. In summary, EDs play a crucial role in antimicrobial stewardship due to the high volume of infection-related encounters and the significant use of antimicrobials. However, they are underrepresented in stewardship efforts. Enhancing antimicrobial stewardship in the ED can improve patient outcomes and reduce inappropriate prescribing. Thank you for listening. If you have a question you would like answered, please email it to emily.perry@ndsu.edu.